You're watching Women's Health, LARC, EMA and the AusCAPPS network. Produced by GP Supervision Australia and presented by Professor Danielle Mazza AM, Dr Nadia Lucis and Dr Romy Giles. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
Thank you all. My name is Dr. Candice Baker. I am a rural GP and a GP supervisor and also the Deputy Chair of the Board of GPSA and an SLO in the rural Northwest Vic region. So wear a couple of hats, as I'm sure all of you do as well. Some learning objectives. So this is really aimed at trying to give us more skills as supervisors to support our registrars in teaching skills to do with long-acting reversible contraception, to help us support registrars to discuss contraceptive options and support patient choice, to understand some of the barriers that patients currently face in terms of accessing that cost-effective and reliable contraception, to support registrars to become providers of LARC and at least understand local referral pathways, to understand barriers and enablers to access early medical abortion, and to support registrars to provide information on medical abortion as part of non-directive counselling. And lastly, to support registrars to become providers of early medical abortion or understand local pathways for same. So we're very lucky to have Dr. Nadia Lucis with us, Professor Danielle Mazza and Dr. Romy Giles. I might hand over to them to introduce themselves and kick us off.
My name is Romy. I'm a GP in regional Victoria. I'm working in sexual reproductive health in particular, and also I have a role as a medical educator with the RACGP.
My name's Nadia Lucis. I'm a GP Research Fellow in the Department of General Practice at Monash University, and my key role there is manager of the AusCAPPS network, which we'll be discussing later. It's nice to meet you all.
And my name is Professor Danielle Mazza, and I am the Professor and Head of the Department of General Practice at Monash University, and I'm the Director of the Sphere Centre of Research Excellence, which is a NHMRC-funded centre aimed at increasing access to and improving the quality of health services delivered to women in women's sexual and reproductive health. And we're absolutely delighted to be partnering with GPSA to deliver this webinar to really raise these issues with you and help you to support your trainees in your practices, and to let you know a little bit about some developments in this sphere and some revisions to the resources and some new resources teaching plans for you. I'm going to go through a little bit about why this area is so important for your trainees in particular, and some of the barriers and enablers to them practicing in this area. And then I'll hand over to Nadia first to talk about the contraceptive part, to Romy around early medical abortion, and I think Nadia is going to finish up by telling you about our AusCAPPS network, which is a fantastic community of practice that we want to encourage you to join and the GP trainees indeed to join. So just a little bit about the background. You'd think that a country like Australia would be doing well in this space, but really we're not doing all that well at all. If you look at unintended pregnancy rates in Australia, this is impacting about 40% of Australian women. The world leader at reducing unintended pregnancy is actually the Netherlands. The implications of unintended pregnancy is that while some women may go on to keep the pregnancy and have that child, a third of unintended pregnancies end in abortion. And there are some figures thrown around, like about 1 in 4 women in Australia will have had an abortion at least one abortion during their lifetime. So this is not very common, but it's not an uncommon event, and it's a common presentation, particularly for the GP trainees who are young themselves and often see young women in this situation. The other area that is interesting to reflect on is that while 2/3 of women of reproductive age use contraception, we know that the most common forms of contraception being used are short-acting methods like the combined oral contraceptive pill or condoms, barrier methods, and that these methods are less reliable and less effective than the long-acting reversible methods that are over 99% effective, and by that I mean intrauterine devices and hormonal implants. At Sphere, we've done some research that has shown that uptake in Australia of LARCs is languishing at around 11%, about 6% of those are IUDs. And when you look internationally, the benchmark is really between 30 and 39%. We've got here 31% in Sweden. I think in Denmark it's sitting at 39%, and the majority of those are actually IUD. And this is in reproductive age women, the forms of contraception they use. So we're not doing very well, and I'll go through a few of the reasons for that. The other area where we've got some issues is around the access to early medical abortion. And while the TGA moved to deregulate early medical abortion and remove all of the stigmatizing restrictions that had been placed for probably more political reasons than anything else in 2023, at that point in time, only 11% of GPs had undertaken what was at the time a mandatory training requirement and certified to become early medical abortion providers, and only 30% of pharmacists were registered to dispense this. So women don't really have a lot of confidence that if they need an early medical abortion, that they can turn to their GP for this, because so few are actually at that point in time, 2023, were providing this service. So more needs to be done to ensure that there are more providers in primary care. So why is it important to be able to access these services? Well, we know that increased use of LARC results in lower rates of unintended pregnancies and abortions, and that might sound a bit kind of obvious, but we've been able to demonstrate through research in Australia that if you invest in general practice through GP education around LARC and provide rapid referral pathways into LARC insertion clinics if GPs themselves are not providing LARC insertion, then you get much bigger uptake of LARCs, and you also get reductions in unintended pregnancies and abortions. And unintended pregnancies bring about poorer maternal and child health outcomes and poorer outcomes overall for the families in terms of educational and socioeconomic outcomes. Pregnancies are more risky also than abortions. And we know also that there are higher rates of unintended pregnancies in rural areas. So having LARC and medical abortion services accessible in these areas is particularly important. And of course, it's very important to offer LARC to women because it is such an effective product and also has lower overall risks than estrogen-containing forms of contraception. So there are a lot of barriers to women accessing LARC at the moment. They have, if they're not offered it, they don't know what they don't know. So they have limited access to information, and the information that they do get from TikTok usually and from Instagram contains a lot of misinformation, and worldwide and in Australia we're also seeing a turn away from women using hormonal forms of contraception. Then they find if they decide that they do want it, there are issues in getting access to these services with low numbers of providers in the community and high out-of-pocket costs. Practitioners themselves are struggling to get access to supervision and training around LARCs and have complained about the high costs of training and the high costs to them of taking time out and from their own practices to train up, and the lower MBS rebates for these services. So the government has actually listened to this, and you may be aware that prior to the election there was a large women's health budget announcement, and Medicare rebates are going up for LARC insertion. There are now scholarships that GPs can apply for, and your GP trainees can apply for, to help support LARC insertion training. And in the next year or so, there's going to be centres of excellence in LARC established in each state to provide not only training for primary care, but also a rapid referral pathway to insertion for those women whose GPs don't provide this service. So this is why we're here talking about all of these issues. GPs are a very trusted source of information, and our trainees are really looking to you as supervisors to help them along the pathway to becoming providers of both LARC and EMA. And from there, I'll hand over to Nadia to continue the webinar. Thank you.
So my section is contraceptive choice and long-acting reversible contraception. And what we are going to be discussing here is how you can support a GP trainee to discuss all the contraceptive options, giving people choice, and how that includes long-acting reversible contraception. What I would like to talk about first is what information a GP trainee might find really useful to start discussing contraception. This is sort of just some background information that follows really the teaching plan that we have updated, and also a new one we've developed, and we'll go through those in a little bit more detail later, where you'll be able to access those soon. So I just wanted to draw your attention to a really excellent article that came out in the Australian Prescriber a month or two ago, and this article really summarises the key elements of the much longer RANZCOG called guideline on contraception. So it's a really digestible format, and it's a really good update on both long and short-acting contraception. So that's a really good place for GP trainees to go to first. And also if you sort of need an update on what's happening in this space, that's a really good resource. It's also got a podcast version of that for people who prefer to listen rather than read their updates. So that's a really good sort of starting point for any discussion on contraception. I thought we'd structure this around a case to make it a little bit more interesting. So we're imagining that a GP trainee, or it could be yourself, is seeing a 25-year-old woman who's an electrician, and she's come in for a repeat of the combined oral contraceptive pill, Leblin, that she's been on for 5 years. She's new and just moved to the practice, so is seeking a new GP. She doesn't have any concerns over using it. She's got a regular cycle and no symptoms that are worrying her regarding using the pill. And she's otherwise a well person with no other significant history. Now, you always remember that people's history can change over time, and you can't be absolutely certain what has been discussed at previous consultations, and also how much a person may have remembered about the information they've been given. So you ask some standard questions about that you always do when you're re-prescribing something that someone has been on for a long time, or potentially thinking about alternatives as well. On further questions, she does sometimes forget to take the pills, and she says she had an early medical abortion about 2 years ago. She's also noted that she's had infrequent migraines for several years, but on questioning the last couple of years, they have been associated with an aura, which for her was a visual disturbance. This sounds very much like a classical migraine with aura. So you also go through some other standard questions that you might ask when people have come in asking advice about contraception, or in this case, just seeking a repeat pill script. So you also like to cover cervical screening, find out about her sexual partners and any concerns about whether she may be at risk of sexually transmitted infections. You also are in the habit of asking people if they do actually want to get pregnant in the next few years or not, because that also helps with the decision making about what might be a good contraceptive option for a person. You also check about any risks of reproductive coercion, which in this case was not present. So far, you've picked up that there's a risk factor here potentially for prescribing a pill, and it's a common one, the classic migraine. So GP trainees really need to know about this very useful resource as well. So this is the UK medical eligibility criteria for contraception, and there's a booklet resource which is available PDF online, and there's also an online calculator which I'll show you in a moment, and it categorises medications, contraceptive medications, based on low risk, go ahead and use, or are contraindicated for red, based on a particular person's situation. So in this situation with sort of one risk factor around having migraine, it would be quite simple to look up the guideline. But if someone has a complex situation, it's a little bit tricky to look in lots of different sections. There's an online calculator where you can fill in the patient's history, and then that will bring up all the different classes of contraception, different types of pills, different types of long-acting reversible contraception, and tell you what the risks of each particular one are. So this, in this instance, shows that a person who has migraine with aura has a category 4 do not use essentially combined oral contraceptive pills with estrogen in, because there's an unacceptable health risk if the method is used. So you take this information back to your case, and so you explain what the risks are around you continuing use of her combined pill when she's now sort of noted that she's getting migraines with aura. Of course, you'd also discuss that in a little bit more detail and decide if you needed to do anything about that as well. But for the purposes here, we're just looking at the contraception now. And so discuss other options that she might like to consider in this situation now that you recommend that she does not continue the combined pill. And so she agrees to have this discussion, and you explore what she knows and any concerns she might have around other options, because as Daniel mentioned, people get information from lots of different places, some reliable, some less reliable. So it's always good to explore what people know. This is a really useful resource when talking about contraception, both because it shows what things look like and all the different options, but it also gives a sense of how reliable they are as a method of contraception when used with typical use. This is from Sexual Reproductive Health Australia, formerly Family Planning Alliance Australia. They've just changed their name recently. You'll find it on their website, but you'll also find it on lots of the family planning or sexual reproductive health organisations, and each state will have this on their website available as well. So it goes through all the different options. Yeah, thanks, Romy, that's fine. And then on the flip side, it's got some more information about long-acting reversible contraception and why it might be useful, and then some specific questions that you might find useful to go through with patients to help them sort of decide what might be suitable for them. Also, just another tip is, I guess, considering whether you might have any language barriers that make it more difficult to get information across. Consider your need for an interpreting service. There's lots of information also on GHALS and family planning organisations' sites, some in simplified language and some in different community languages as well. Also on AusCAPPS, we had done a summary of medical abortion and LARC information for culturally and linguistically diverse communities. And there's also a site where you can ask questions, but we'll discuss that more in a bit more detail later. There's some other things that would be really good to go through with GP trainees as well, some common myths of contraception, which still come around, and there's probably more that have been developed as well. You can never sort of tell what's happening out in the community. So these are some common ones, that IUDs can only be used in women who've had children, which is really not true. They can be used in women who've not had children, and they can be used in teenagers as well. IUDs and implants make it harder to get pregnant after removal. That's not true. All antibiotics stop the pill from working. There are some issues with some, but not all. Breastfeeding prevents pregnancy in certain circumstances. The pill is the most effective contraception. I think if you look at the chart, you'll see that is not true, but people may have that view in the community. The rod causes bleeding all the time. It can be a side effect, but it's certainly not universal. And IUD insertion is always painful. There's evidence to show that lots of people do not find it painful. Some people will. So these are things to discuss with people, and you might find that you have come across some other myths that you need to dispel, and the registrars, GP trainees may have heard about some other things that you can also discuss and whether there's any truth behind them. The other thing to think about with long-acting reversible contraception is that there are indications for them beyond contraception, and in particular, the IUDs with progesterone and also implants. So heavy uterine bleeding, adenomyosis and endometriosis, dysmenorrhea, and also can be used for menopausal hormone therapy, the progesterone-containing IUDs only, the 52 milligram ones. So there's different reasons to consider using LARC as well beyond contraception. Some more teaching tips: confidentiality, especially for adolescents, and also consider in that group consent for sexual activity, the risk of harm and mandatory reporting requirements. If the oral contraceptive pill is decided it's the most appropriate contraception at the point in time, there are many, many out there. Choose a few and become familiar with them. Therapeutic guidelines, that the way they describe it is that consider the cost, whether it's available on the PBS and what restrictions are in place, and that the proven risks and benefits versus theoretical but unproven benefits. So there may be a lot of hype around particular pills that may have some benefit but not. So just become familiar with a few and decide what you feel comfortable prescribing more easily, and then research others as necessary. If prescribing combined oral contraceptive pills, ask about contraindications to estrogen, so migraine and GORA is one, and also in older women, consider cardiovascular disease risk too. You can discuss different pill regimes with reduced or no hormone-free intervals as a routine part of prescribing rather than having to have a monthly cycle. Don't assume irregular bleeding is contraceptive related, because there may be other causes such as pregnancy, infections and malignancy. Consider overweight and obesity and malabsorption and bariatric surgery, and whether that might impact emergency contraception. And we've also already discussed the consent and risk of harm for younger people. So Katie here has decided she'd like to use an IUD. And at that point, you need to sort of work out how we're going to change from one to the other. So that's a discussion to have with her, how you cease the pill and start the IUD, and considering her situation around the risk of pregnancy and preferences. It also may depend on what the IUD access is like, where you are working, whether it's something that can be done soon within practice, whether they're in stock at pharmacy, all of those logistical considerations. And then you need to organise follow-up. So this is where it can be a little bit different for, I guess, GPs who are and aren't LARC providers, and also the supervisors and others in the practice that are and aren't LARC providers. So if you've got someone who expresses a preference to have a long-acting reversible contraception as their contraceptive choice, how do you support that access in a situation where it may be less easy? So you really need to have that confidence discussing LARC as a choice, even if you're not necessarily at the point of being able to do that yourself at that point in time as a GP trainee. You should have knowledge of the local providers, whether they're in your practice within the region, what are the other options in the area. And there might be practice resources that can support this so that everyone knows what the options are and can easily refer people to. You might have useful health pathways in your area that summarise service provision as well. Also on the AusCAPPS network, we have a providers near you page, which if people are really stuck or just wanted new ideas about who might be providing these services nearby, that is an option as well, because people who have joined can say whether they're providing LARC services. Now, GP trainees may also want to actually become LARC providers. And then I guess the decision is whether there's yourself or another GP within the practice be able to provide supervision or mentoring, or it could be sort of locally rather than necessarily absolutely within the practice. Just to note that non-procedural indemnity usually covers implant and IUD insertion, but people should always check with their own insurer to make sure that's still the case. You should consider what your local options are for training. Does a GP training provider organise something? Is there access through family planning organisations? College of GPs, ACRM may have options. Pharmaceutical companies sometimes do things more so for implants rather than IUD. And there may be other things like education days or online training and simulation as an option. So we just mentioned earlier, Danielle, at the beginning of the talk, that there are some scholarships for LARC training coming up. So the Sexual and Reproductive Health in Australia, in partnership with RSUGP, has scholarships available through the State Family Planning Organisation. It's called AusLARC. There's the website link on the page there that you can see. The scholarship's open on the 1st of September, but you can actually go on the site now and express your interest, and that's to expand capacity to do more training for Implant and IUD for eligible health professionals above and beyond what the training would have already been available. So that's a really good option, that if people are interested in training, whether it's yourself, people on this webinar, or people that you're in contact with and GP trainees that you're supervising, that would be a good place for information and express interest if people are interested in becoming a provider. What do you do if someone has been trained to insert LARCs? Who can help after that? So got GP supervisors and other mentors who are set up in place for when a person undertook training. But we'll also discuss AusCAPPS. I feel like I'm mentioning it a lot and spruiking it, but we'll discuss it in more detail. People can join the AusLARC network, which is an online community of practice where you can ask lots of questions. There's regular updates as well. We'll talk about them all later. We've also got some resources coming out soon. We've been working with General Practice Supervision Australia on updating the contraception resource, and then doing a complementary long-acting reversible contraception resource that provides a little bit more detail on LARC compared to the contraception one, but they're probably best read together. They will be available soon on the website. They're not quite there yet. And then we've also, and we're not really covering this in this talk, but we've also been updating the one on endometriosis, which will be available soon as well. It's relevant to our work, though. We've got other projects working on endometriosis management, and also need to remember that long-acting reversible contraception is a useful option for management of endometriosis. I think that's the end of my section, so I'm going to hand over to Romy for early medical abortion. Thanks, Romy.
Thanks very much, Nadia, for that. And yes, I think being a LARC provider is a really rewarding part of your general practice, to be able to, provide those services in-house for your patients. So I would definitely encourage those that are on the fence to make use of the scholarships and the backing behind this that's coming. I am going to talk now about early medical abortion and how you might best support your registrars to undertake this in your clinic. And also, I guess, if you're not currently providing, this might give you some more confidence or the inspiration to become a provider yourself. So we highlighted these at the start, but essentially we'll talk a little bit and reference the barriers and enablers for access to early medical abortion, and we'll touch on the legal, ethical and social issues we want you to be able to support registrars to undertake this really important part of reproductive healthcare, and hopefully encourage registrars and support them to become providers themselves and have an understanding of local pathways for abortion care. We've covered a little bit of this already, but just to go around the background around early medical abortion. So RAMSCOG released a statement earlier this year, or towards the end of last year, around reproductive healthcare really not being complete without equitable access to abortion. So it's something that we know we need to fix, and as Danielle mentioned at the start, it unfortunately remains really difficult for lots of people across Australia to access, and that's for a number of reasons: geography, cost, limited providers, which Danielle touched on the stats for that, and unfortunately still stigma and discrimination that a lot of patients face when trying to access abortion care. Currently in Australia, early medical abortion, so that's medication to end a pregnancy, is currently approved up to 9 weeks, but there are some movements towards whether that might increase to 10. There was a mention before about the mandatory training. So there used to be mandatory training in order to be a registered prescriber for early medical abortions, and that was removed. The restrictions for that were removed in 2023 in order to get rid of another hurdle people were facing in order to undertake this aspect of patient care. It's safe, it's legal, it's effective, The failure rates in terms of ongoing pregnancy are really very, very small. I think the Australian stats are 0.76%, so it works. And we know from lots of data in Australia and overseas that it's really safe for most people. And the medication itself is something called MS2-step, so it's mifepristone and misoprostol, 2 medications used in a 2-step technique. So it says what it does on the tin. I suppose it's got that in the name. Things that I think are really useful for you to either undertake yourself or encourage your registrars to do in any of your education sessions with them around early medical abortion. Even though the restrictions have been removed and the training is no longer a mandatory requirement in order to become a prescriber, I would still really encourage you to do the MS2-step training. It's really useful. It gives you a really good platform and kind of understanding going forward. In Victoria, we've got 1-800-MY-OPTIONS, so they've got ability, they're basically a contraceptive and abortion website with information and also the ability to register as a provider, and other professionals, but also patients and clients can have a look and see what providers are available in their area. The Royal Women's Hospital in Victoria has a really fantastic early medical abortion clinical pathway guideline, and also some relatively new online training modules which you can work through as well, or your registrars could work through. We've talked a bit about AusCAPPS already, but we'll talk about it a bit more, but it's another really great resource and a place where you can go to, discuss, raise topics yourself, find out previous topics of discussion. Queensland Health Guideline, termination of pregnancy, is also a really useful guideline to use, and then the RANZCOG abortion guidelines, and also a really fantastic decision-making tool that they have as well, which you can use with patients. So some really great resources to be familiar with and to share with your registrars if they don't know about them already. We're going to talk through a case because I think case-based learning is the best way to do it. So we're going to use Renee, who's 27. She comes to your clinic with an unplanned pregnancy and wants to discuss her options. So what are some of the things we might think about doing ourselves, but also supporting registrars with? So in order to try to break down some of these barriers of stigma and discrimination that patients feel, we want to make sure that we're approaching this in a non-judgmental way. It's really trauma-informed and sort of culturally responsive care. So patients have often really considered this in quite a lot of detail and are feeling quite nervous about presenting to health professionals. And so enabling them to have a straightforward experience and feeling not judged by their decision making is really, really important. We're going to be applying a non-directive counselling approach, to which there are additional item numbers for billing purposes if you do the required training. But essentially a non-directive approach is allowing patients, and we use this a lot in clinical practice in other areas, not just in the context of early medical abortion and pregnancy decision making, but really enabling and empowering someone to have a safe space to make a decision that's right for them. So providing them with factual information, not guiding them to a decision, but allowing them that safe space to consider all the options and come to the decision that's best for them. Another thing to think about is elements of consent, capacity, and we've touched on that with Nadia already, but it's really important to make sure that we talk about reproductive coercion and safety. Unfortunately, we know that reproductive coercion is a significant factor in family violence situations, and it's a really useful time to consider exploring that with patients. We also know that pregnancy is a high-risk time for family violence, and so this is a really good opportunity to make sure that this decision-making process has come from the patient themselves. And we've been doing this throughout these teaching points already, but we want to make sure that we're helping to break down barriers and stigma to abortion access and making this something that patients can have ease of access to and a straightforward process for them. And there is a link which I think will be provided extra as well, but just there's a reflection exercise that I came across that I think is really interesting and really useful to do, either yourself and for registrars. Some of it is quite confronting, so it asks some quite challenging questions about your bias, how you feel about this process, and I think it's a really valuable exercise to do individually, but I also wonder if you felt comfortable and if the registrar felt comfortable, it'd be a really fantastic resource to go away and work on and come back and discuss together. Obviously, that depends on yourself, your registrar, and the relationship that you've got. But I think if that relationship was there and you both felt comfortable with this would be a really valuable exercise to undertake. So going forward with Renee, we've applied the non-directive counselling session, and we've explored her values and wishes and what she would like to do in this instance with providing her information to make that decision. And she decided that she doesn't want to proceed with the pregnancy, and she reports no reproductive coercion and there's no safety concerns. So the next things we're going to be thinking about in terms of this case would be a determination of gestational age. As we've discussed already, there are some limits around timeframes for early medical abortion. So we need to determine if early medical abortion is a suitable option for Renee at this time. Now, there are a number of ways, or at least a couple of ways of doing this. Traditionally, or the sort of safest way to explore the location and also stage of a pregnancy would be by doing an ultrasound scan. There is also option to do clinical history. So if you have someone that's got really regular cycles, and we know when their last menstrual period was, we know that they're that they're not past the cutoff date for an early medical abortion, we might choose that as a determination of gestational age. There's lots of factors where we may want to use an ultrasound scan, and it really comes down to the individual preference, safety, screening, availability, and obviously practitioner comfort as well. But we want to find out gestational age. We want to explore eligibility and contraindications for EMA. So early medical abortion can be used up to 9 weeks, as we mentioned, and potentially 10, but currently the guidelines are 9 weeks. It cannot be used in a suspected or confirmed ectopic pregnancy. It can't be used in untreated pelvic inflammatory disease, chronic adrenal failure, concurrent long-term steroid therapy, any bleeding disorders or anticoagulant therapy, any hypersensitivity or allergies known to prostaglandins or any of the other ingredients, and also within an IUD in situ. Other factors are lack of access to medical care, so we need to make sure that she's within 2 hours of a hospital that could manage any bleeding in this context, and also in the 2 weeks after she's commenced the medical abortion as well, that she will have appropriate access to healthcare. Some of the other things, and these eligibility criteria and contraindications are all really freely available in all the documents and resources that we've highlighted already. Other things that you might think about are things around social issues, safety, does she have somewhere safe to live? What's her housing situation? Does she have support around her? We've already talked about family violence, but is there any family violence element? And then any other religious or cultural implications that might make this a difficult process for her. Once we've determined that she is eligible and the option of medical abortion is there for Renee, we want to talk to her about the options. So we want to, explore, and I usually do this in a kind of nutshell approach of here are the pros and cons of a medical abortion, here are the pros and cons of a surgical abortion. Again, really specific to the area that you're in, the access to service that you have, but just allowing that decision-making process for someone that has both options available to them. So we move through all of that with Renee, and she decides that she would like to proceed with early medical abortion, that would be the right choice for her, and we've found no contraindications to this, which is great. Renee's periods are irregular, her cycles are irregular currently, and so we don't really know when her last normal menstrual period was. So because of the issues around the irregular cycles and not knowing when her last period was, we're going to proceed with an ultrasound scan to confirm gestational age, and also which will confirm for us the location of this early pregnancy. I think it's really important to, if you are going to be providing early medical abortion and supporting your registrars to do this, to try to develop some networks and some relationships with your local imaging providers. Due to the time-sensitive nature of this care and the provision of early medical abortion, it is useful to have a phone a friend that you can contact who might be able to fit someone in or squeeze people into lists, because ultrasound can be a tricky thing to arrange, particularly if you're in a regional or remote area. We're also going to arrange some pathology. So usually you would do a serum beta HCG to get a baseline reading, which we'll use for comparison down the track following the procedure. We might also use that as a rough marker to match the gestational age that we see on the ultrasound, just to give us that extra confirmation that those two things align, noting that there's a really broad range for serum beta HCG. We'd also at this stage, and I really recommend this, opportunistically discuss STI screening, and we certainly would encourage all of our early medical abortion clients to undertake STI screening. Obviously, if they decline, that's entirely their choice, but we would encourage them to do that. This should not delay, though, proceeding with the early medical abortion, and things can be treated and the early medical abortion can continue. And we would also check CST status at this stage, because again, useful thing to conduct whilst you're doing those other swabs. It's really important to note that other pathology, so hemoglobin and blood group, is not indicated routinely. So really, unless there's a clinical concern around those elements, we wouldn't be doing that. And that anti-D is no longer required for any bleeding in early pregnancy or abortions up to 10 weeks in Australia. So we don't need to do a blood group for those clients. So Renee comes back with the results we've asked her to do. Her serum beta HCG returns at 1,998, which, as you can see, fits in a lot of the categories, but somewhere in the region of between 4 to 6 weeks. And then her ultrasound report demonstrates an intrauterine single gestation. There's a yolk sac and fetal pole, and on measurements, it's approximately 6 weeks and 4 days gestation, which fits roughly with what we were looking at with the beta HCG. So now we're happy that she's within 9 weeks gestation. We can proceed, and we also know the location, so we've ruled out an ectopic pregnancy for Renee as well, which is great. Things that we would do next. So this is a really important thing to get used to explaining to patients, and having a sort of blurb that you undertake, and again, supporting registrars with this. The expectation setting of the likely symptoms and the pattern of bleeding following an early medical abortion is really key. I think patients really appreciate the honesty and upfrontness of that there will be heavy bleeding, that indicates things are working. There's passage of clots and material, which is a really normal expectation of the process, and that the pain usually gets intense, at least for a period of time. So having those really upfront conversations. Also, when you have those conversations, outlining what you might do to help that, in terms of usually there would be an analgesia prescription and also some antiemetics prescribed with the MS2 step to alleviate some of those symptoms, but having a really good understanding of what they should expect. The other thing that's really important, obviously, is to talk about what to expect, and also to talk about what to look for in terms of when possible complications might arise and what those possible complications might be. So again, having a system, and that may be a document that you read to the patient and they sign, or a process whereby you document that a different way, but having a really important discussion around what the complications are, noting that they are all low risk of occurring, but it's important to have that conversation, and then being able to identify early if we think any of those complications are arising. There's a really useful resource about abnormal or pathological bleeding. This is from the Royal Women's Guideline of sort of management following an early medical abortion, and I think this is a really nice, concise framework to look at in terms of the duration after taking the medication, what might be abnormal or considered abnormal at those stages. So again, just being familiar with those resources and sharing them with your registrars to help support them with the decision making if complications do arise or questions are asked by the patient about bleeding that they experience. Talked about that, so outlining things. Follow-up is really important, so making sure that you've got a clear process for following up your patients. Also making sure that there's a process for them to be able to contact. How will they contact the clinic if they want to discuss something before their routine scheduled follow-up? How will you manage that? So some of those logistical considerations, I think, are really important to to have organised and in place before you start providing the service. Talked about possible complications, so making sure there's really clear information. Things like handouts are really useful. We have a handout, a guide as to how to take the medication, and also within that is a list of what to look for around complications, and then numbers and contacts on that document too that we provide all of our patients at that time. Really important to flag early return to fertility and initiate contraceptive options discussion. This is a great opportunity to talk about these things and make sure that we're addressing that at this stage. And then I think with registrars, it'd be a really useful point to, once you've either finished the role play or had a discussion of things, or after they've seen their first patient, to repeat that reflection exercise and make sure that you have an opportunity to debrief with your registrar. Just quickly going through the ethical, legal and logistical things. So we've mentioned this already, but currently legal in all states and territories, some new also gestational limits for later stage abortions, but not for early medical abortion. I think it's really important to have a discussion with your practice staff around, if you are going to provide this service, how might that actually happen from the time the patient phones looking for this service? How is that facilitated for them, noting that GP appointments are difficult to come by and there's often a waiting list to see someone. So how are we going to navigate that in these patients where there's a time critical element? I think it's really important to be really comfortable and familiar with your own boundaries, beliefs and your position, and how you might translate that or not to care of these patients. And if you do decide to conscientiously object, then being comfortable with the way that you explain that to patients, and also making sure that you're complying with the requirements around referral options. I think it's really important to explore the issues around early medical abortion delicately with registrars, not assuming that they share your perspective or that they don't, but also whilst always trying to aim to reduce the stigma and barriers to abortion care that patients expect. Another really crucial thing, I think, is what happens when you're not there. So if you're a supervisor and you support your registrar with early medical abortion and you take leave and someone else is covering for you in terms of supervision for general patients, does that person also undertake early medical abortion? Are they happy to step in to manage and support the registrar? So again, just thinking about those logistical considerations. It is a really valuable thing to be able to help your registrars with. One of the common things that the 1-800 My Options team find is that we have registrars calling looking for a provider of early medical abortion, and when we explore with them that it's something they could undertake, often one of the limiting factors is that they don't have a supervisor who will work with them and be supporting them to provide that. So it is something I'd really encourage you to add to your practice for your patients and your community, but also for your registrars that are coming through your clinic. Just a list of some resources that we find really useful. I've kind of highlighted them already, and they'll be shared. I think they're on the website, or they'll be shared separately. And then obviously the reason we're here is we're really grateful to be partnering with GPSA to help hopefully upskill people and bring knowledge on these topics, but also to create this teaching aid on early medical abortion for you to follow with your registrars. Thank you very much. Hand back over to you, Nadia.
Thanks very much, Romy. So I'm just going to briefly talk about the AusCAPPS network at the end of our talk to wrap it up. Okay, so the AusCAPPS Community of Practice, it's an online network that supports practitioners providing contraception, and in particular long-acting reversible contraception and medical abortion. It's supported by a wide range of stakeholders. You can see all of the ones there. There's a range of different health professionals, family planning organisations, Gene House for Women, Children by Choice. At the moment, there's 3,000 members, and GPs make up the majority of members. There's about 60% GPs, but there's also a significant cohorts of community pharmacists, nurses working in primary care, midwives, and a few other practitioners as well. Anyone who's got an APRA registration is welcome to join the network. This is just to give a brief overview of what's on there. Probably the most used pages are the chat with peers and experts pages. And we've got regular content by various clinician leads, and Romy's actually one of them, providing regular content to the network. And we've got other GPs from around the country, plus community pharmacists and nurses, and also soon to be midwives. We've got family planning organisation staff who also are now making regular contributions. So there's regular case studies and also updates on changes in practice and changes in guidelines and changes in policy. So those updates are provided regularly, but it's also a page where people can log in and ask whatever question you like. So you can ask to the community and other people in the community can answer. The clinical leads that are working on AusCAPPS can answer as well. So it's a really good resource to get evidence-based information for you to sort of solve your clinical conundrums. Other pages on the site are providers near you. There's also a topic library that we've summarised lots of the discussion posters and the resources that are available. There's a resource library that's got lots of evidence-based guidelines and also some patient and practice resources. There's some webinars and podcasts about LARC and medical abortion, and we also regularly promote training that's available in LARC and medical abortion, including the scholarships that are coming up. And so this is one of our promotional brochures for AusCAPPS. If you're there with your phone, you can scan the QR code if you like, but otherwise you can search up under Medcast and AusCAPPS and you'll find us online. And it would be a really wonderful thing if you're providing LARC or medical abortion to use this network and contribute to it. But it'd also be wonderful if you're supporting GP trainees who are just new to prescribing contraception or new to providing LARC insertion or medical abortion. This would be a really good additional resource in addition to GP supervisors and others in the practice and wider networks to support an individual as they're learning about something new. So that would be great if you can promote that, get further conversations happening on the site. And I think that's wrapping up our talk.
A big thank you to all of our panellists. That was a wonderful session, and I think I certainly took a lot out of it that I can bring back to the teaching of my registrars. So thank you so much.
Thanks, everyone. Bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.